out of their own pockets can do so. In other words, two healthcare systems, one basic, one elite, which reflects the America that we are and are going to continue to be for a while.
No, it's a great point, and I think many other countries have that two-tiered system now. You know, countries that have universal health care also have, you know, privately, you know, accessible health care for the wealthy, you know, that get better health care. Like Professor Barnes said, I mean, if you go to some of these other countries, you know, if you go, like I was over in Italy, and Italy has national health care, if you go into the public hospitals there, you'll see vastly different hospitals, whereas if you can afford to pay out of pocket, you can go to private hospitals. You get the same doctors that you potentially could care for you in the public hospitals, but you might have to wait a really long time. They'll see you right away in the private system for cash out of pocket. It's a much different system, and I think you could potentially have the same thing develop here, like you said. I think one of the big things that will determine that is the employer-based healthcare system in this country. You know, what's going to happen to it? Employers are jumping out of healthcare as fast as they can, and in fact, even though the Chamber of Commerce, you know, even though there was business resistance against the healthcare bill, I'm not sure why sometimes, because for a lot of businesses, it will give them the ability to not have to offer healthcare to their employees. Yes, they'll pay a penalty, but the penalty will be a fraction of what it would cost them if they actually had to fund healthcare for all their employees. So I think that's one of the determining features moving forward. You know, if we maintain a strong employer-based healthcare system in this country, you may not see this two-tier system, but if more and more employers start to back out of healthcare, you could have exactly what you're talking about.
I just want to add to that. I think it's interesting, something I've played around with over the years, to think about, is this on? Yeah. To think about the comparisons between healthcare and education. And if you think about it, that's what we have with education, right? And it's interesting to me, why don't we think about healthcare in the same way? In education, we do think, it's not a constitutional right, but we do think that the government has a duty and obligation to provide every child with some K-12 education. Not always very good, and we could do the international comparisons on that one too, but there is some education. And we do have high rates of literacy. We may not be lead in the world in math and science, but we do get the basic literacy. And then we also know, of course, that the affluent significantly send their kids to private institutions and opt out of the public system. And you could imagine a healthcare system somewhat similar. I would also add that we were closer there once upon a time. We had a more robust system of public hospitals and public infirmaries in this country. People might remember Boston City Hospital used to be, Boston Medical Center used to be Boston City Hospital. We had actually a lot more public health care. We privatized it in the late 20th century. We do still have community health centers, but they're not everywhere in the country. But they are providing some of that.
So I get from what we've heard here tonight that we need reform, but I'm not sure whether we've gotten to that tipping point where the average consumer of healthcare in the United States feels that things are so badly screwed up that they're going to push for reform. And I'm wondering if there's another example of a system that ultimately got reformed that was in the state of what, if you look at something closely, you say, oh my God, this is horrifying. But if you look at the majority of people, they're probably pretty okay with how they get healthy if they're sick. I mean, it's the exception that really understands, it's the people who have a surgical disaster or it's in the main, it seems to me that the system doesn't appear to the average consumer to be a disaster.
Well, that's certainly true. I mean, most people don't really know what they are paying for healthcare, right? I mean, you know, I don't stop every month and think about how much Northeastern pays for my healthcare. I don't think about that. And most people don't. And most people don't think, I mean, some of the things we were talking about, you know, the fact that you could live longer in other countries, that's not obvious either, right? What's obvious is if I need care and I can't get it, or I go to the ER and I'm turned away. That people get. And it's interesting because in 1986 we passed a law that was known at the time as the Anti-Dumping Act, right? And it makes it illegal for hospital emergency rooms to reject people on the basis of ability to pay. And to some extent, what I thought was interesting is that kind of took away the obviousness of the problem, right? We could say people aren't dying on the streets, and they're not dying on the streets, so we don't see the problem. I don't know when the tipping point is, right? Nobody thought the sequester would last more than a weekend, and now it seems, I mean, I don't know what it takes to get a push for change in this country at this moment in time.
You know, there really isn't an example of another country that got to this point and then reformed, because, you know, like any country, healthcare is intertwined with the political system, with the social system. So many countries have had universal healthcare forever because they've had socialist, you know, political systems, socialist cultures. So that's one. There really is no other example. I mean, this truly is American exceptionalism at its finest. But I will tell you, from a business perspective, the consumer will, no matter how they're insured, they will soon see the new landscape of healthcare over the next decade, which will be aggressive management to deliver better value for the patient, but you're going to increasingly find you may not agree with how that value is defined, because it may start to become about limiting choice. It may start to become more about not denying acute care or elective care, but certainly extending it and maybe, you know, having to wait longer for things. More aggressive management by the primary care system that you're in. And, you know, so I think, you know, regardless of whether you want to call it rationing or, you know, managed care like we called it 20 years ago, I mean, we are headed in a direction where the public is going to, regardless of how they're insured, they're gonna have less choice and potentially less voice. It's odd that we're supposedly in the moment of consumer-oriented healthcare, but I worry that the consumer over time is gonna have less actual voice in their healthcare, and I think that's something everybody should worry about. You know, I have good friends back in Albany, where I'm from, who work for GE, right, and you know, companies like that have moved to high deductible health plans, health savings accounts, where they give the employee money and they say, here's $10,000. Here's some health plans we could pick, but you pick them and we're out. We're not going to get involved in it. It's you and the health plan, and we'll help manage it. And that's a troublesome trend, because that's shifting the cost potentially and the burden to the consumer to have to worry about getting affordable health care insurance, getting right care health care insurance. So I think in that sense the tipping point may be coming, because I think all consumers are going to soon know what state the system is in from a cost perspective.
Just one comment on that. You just said about we don't have a socialist system, and I would just be very cautious about using that kind of terminology, because it seems that, you know, Germany's a capitalist system, Canada, Great Britain, but they have a different kind of social safety net. And so, because I think that's part of why the American resistance or to seeing anything wrong with this system, because we don't want to become socialist. And it's not that we're not a capitalist nation with a social safety net, the other one.
Well,
Sure.
I think one way we're exceptional, and I want to make it again, is that this is an area in which our constitutionalism causes us trouble. You know, we're not a parliamentary system. We have a constitutional structure that is designed for gridlock. there's a lot of good to that, but our whole Constitution is designed to disperse power. Makes it much harder in the US than in these other countries where you get a parliamentary majority, right, to impose, to change. I mean, there were certainly periods of great change, like the New Deal in the 60s, but it's much harder in this country than in other countries. And then you layer on top of it the federalist system. And there are, Germany's a federalist system too, but it's deeper constitutionally here. You don't have the kinds of things that you have here with the court saying the federal government, the national government can't require states to have health care, right? So we have a constitutional structure that in a sense works in tandem with that ideological and political culture, I think, all together to make barriers to reform here.
Well, and I also mean, when I say so, I mean, I mean the culture too. We used to think that income redistribution in this country was okay. Back in the 50s and 60s, the highest tax rates and the top earners were over 90%. Now we're down. Now we fight over, is it going to be 35%, 36%? Where in other countries, they fund their healthcare systems by taxing, their wealthiest citizens up to rates of 50, 60, 70%. We used to do that, and we don't do that anymore. That's another problem. We don't generate the income anymore from the top earners to be able to pay for things to give to other citizens in the country, and it comes down to dollars and cents sometimes.
Wendy had a nice chart that showed by state the insured coverages. Do you have anything that shows the healthcare outcomes, the life expectancies versus the insurance, the uninsured coverages?
I don't have any with me. Life expectancy is complicated because there's also a lot of mobility, and life expectancy, you have to look at a lifespan issue. So experiences that we have as a childhood in one state affects our longevity many years later in another state. And I don't know, as I said at the beginning, if you look at life outcomes, if you look at overall mortality rates, Massachusetts is in the range of most of Western Europe. I don't know state by state. I know Vermont and Minnesota are pretty high too. And if you look at, I could have done a map, and I've seen them, I just don't have them with me today. If you look at obesity rates, if you look at smoking rates, if you look at teen pregnancy rates, you're gonna see something that looks awfully like, I shouldn't say it, but the election night map. It's significantly the red-blue divide. And the southern states in the United States in particular just do much worse on all health, population level health outcomes. Now again, over the course of a lifespan of mortality, it is complicated. And there are confounders. I mean, Massachusetts does very well. It's not just our health insurance. We have very high rates of education in Massachusetts, right? We are a much wealthier state than Louisiana or Mississippi or Alabama. So there's a lot of confounding going on. And, but it would look at most population health outcomes. It's going to look very similar, both proximal and distal. It's going to look very similar to the map I showed about insurance. But I don't think it's all insurance, again. I think it's all these other lifestyle and income and social determinants too.
Yeah, I mean, generally the states that have the lowest morbidity and the lowest mortality are states that tend to be wealthier and have more highly educated individuals. So, that, like Wendy said, those are big confounders when you're trying, and they also tend to be states that have a higher number of insured individuals. So you got to tease out each one of those things, which is the thing that's really causing the decline in either, increased morbidity or increased mortality.
When people talk about single payer and rugged individuals in the United States don't like that because everyone should be taking care of themselves. If a company is paying $10,000, $12,000 for my insurance, that company is having to increase the cost of the product in order to pay for that. So anyone who buys that product is paying into the health care of the person working for that company. If a hospital cannot get payment for a person who comes who is indigent, then everyone else who goes to that hospital is going to have his or her bill jacked up to pay for that. If there is an epidemic and many, many people get sick and go to the hospital or have to pay doctor's bills and buy medicine, we all pay for that. Why doesn't anyone say this?
Well, I think you're right on. I mean, you're dead on. I mean, somebody pays for the care that's delivered to individuals that either are underinsured or uninsured, right? Hospitals used to call these things bad debt and charity, okay? In the healthcare reform law, the hospitals will no longer get what's called disproportional share payments, which means hospitals that take care of more indigent will have payments for those indigent from the government reduced. The deal that they made, though, is that more individuals will be hopefully signed up for Medicaid and get more insurance through the exchange. So for hospitals, they're thinking, well, I'll get more customers that actually have insurance. So even if those payments are reduced, I'll make out. Who knows? If Medicaid doesn't get expanded in these states, if the health insurance uptake doesn't happen among the lower segments like we expect it to, then hospitals are going to be providing even more care without getting those payments. And how are they going to redistribute that? They'll redistribute it on the backs of middle-class insurance. They'll redistribute it on the backs of Medicare, the Medicare program. So it's absolutely true. Redistribution happens. And I think the arguments out there, it's just people don't necessarily see it hit their pocketbook yet, right? The insurer sees it. The employer who self-insures sees it. But maybe the patient doesn't see it yet. But again, some of this move to high deductible plans, health savings accounts, consumers are going to start to see this take place, because they're going to be the ones that they're going to be given a finite amount of money from their employer to buy their health insurance, and that's going to limit what they can buy in the open market. Anything more, they have to pay for. But unfortunately, that kind of reality doesn't hit individuals as much yet, largely because most of the costs that get shifted onto employers who've paid for insurance this whole time, or get shifted onto insurance plan that insures workers, and the consumer hasn't really seen it. And that I think is part of the problem. I mean, we've talked a little bit tonight, each of us, about how the individual has been largely removed from a lot of this bad stuff that's happened. And that, I think that's part of the issue, at least for me it is.
In the popular press, there is a lot of criticism of pharmaceutical companies for contributing to the high cost of medical care in our country compared to the rest of the world, where pharmaceutical prices are generally lower. Could you comment on how pharmaceuticals affect the cost of care versus other parts of the world, and how in the United States they affect the value contributed to care versus the other parts of the world?
Pharmaceuticals, you didn't have the slides, but if you look over time, it is true that pharmaceuticals have taken an increasing share of the dollar, right? We spend more and more on pharmaceuticals, and we do pay more in the rest of the world, both because we pay more per gram, but also we medicate more than the rest of the world. We have an aversion to price setting. There are countries where the government negotiates with pharmaceutical companies about what is the price, and we don't do that in America. We have. One of the things I think it's really worth noting is that people talk about Obamacare as this massive regulation. We used to actually have a much more regulated healthcare system than we have now. we made these changes over the last 3 decades of the 20th century, but we used to set the price for hospitals, okay? When I started teaching health law, we had hospital rate regulation in Massachusetts. We don't anymore. But there are countries that continue to have the government negotiate with manufacturers, and so what you see is lower prices than here, but I don't have the cross-country.
No, I mean, you're right. I
price
mean,
data.
we are charged so much in this country because, you know, pharmaceutical companies just cost shift the prices that have to be limited and regulated in other countries, that are, the costs are shifted onto our prices, so we pay more because we don't regulate the prices. And, you know, we pay for the marketing that pharmaceutical companies do for their drugs worldwide. But, you know, there's stuff in the healthcare law that, you know, the quicker introduction of generic drugs, that's going to limit some of that. I think the other part of the problem that we don't focus on maybe enough is we're pill popping culture. You know, the average person, I think I saw some statistics, gets like 10 prescriptions a year from their doctor. Okay, we take a lot of drugs, and we are, as a culture, overprescribed for everything. I mean, I can't watch the nightly news anymore because every commercial is about Nexium or Lipitor. I mean, it is nonstop, and that's a big problem. The culture of our healthcare system is, if there's something wrong, there's got to be a pill for it. Let's give it to the person. Doctors do it a lot to please patients. Patients expect it when they go in. There's been studies that have done that shown that if patients, for certain conditions or certain symptoms, if they go in and they come out without getting a prescription, even though they may not need it, they're more dissatisfied with their visit because they expect their doctor to give them a prescription.
Since I have to take the point of privilege of the law professor today at this point, one of the reasons we do this, all those commercials, is because we've now decided that drug companies have a First Amendment right to advertise. In most of the world, you can't have those commercials on TV. You can't have the ad telling you, ask your doctor about the little red pill, or even worse, you know, call 1-800, right? The diseases you never heard of, you now know you have, right? We have a constitutional right to advertise pharmaceuticals on television. And what we know is that creates a market, right? They're very good at getting us to think that restless knee syndrome, I mean, I don't want to make fun of anyone's syndrome, but they're very good at convincing us to take things that maybe we could have been fine without, as opposed to going to our doctor when we have a problem and the doctor saying, here's something maybe you should have a drug for. We now go to the doctor, or we call, or we buy it over the internet. We don't even actually see the doctor to get the drug.
We are going to have one session on pharmaceutical industry.
Absolutely.
Yes. And that will be good, a good one. How about maybe one
Here's
more?
the microphone, please.
Maybe one more? Comment, question?
Hi, it's probably a simplistic comparison, but it would almost seem as though if you just moved everybody to Medicare, we'd be better off than trying to have two systems, one for over 65 and 65. It might be a simplistic view, but how would we look in comparison to the other countries, perhaps, if we did?
Well, I think, you know, we'll have, by the way, we will also have some more shameless advertising. We will have a class on single payer, and if we moved everyone to Medicare, it would be similar to a single payer. The devil's in the details, but you'd have much higher rates of insurance, and if you had a single payer, you would probably have a more rational and less fragmented healthcare system, and you would have a payer that could negotiate with these drugs. And Medicare's good at that, right? Medicare is much better than many insurers in getting lower prices. You know, there's some cost shifting from Medicare to other payers, and you couldn't do that as much. But I do want to emphasize again, that wouldn't solve all the other population level issues. It's not just healthcare. You know, that wouldn't solve the obesity epidemic. It wouldn't solve our homicide rate by firearms. It wouldn't solve the teen pregnancy rate, right? It's not just getting everyone insured, but it would make you know, it would have some of its own problems, right? There'd be less choice potentially. So it's not a panacea, but it would provide for higher rates of insurance and probably lower costs.
Yeah, I mean, Medicare is a great program, fantastic program, but it's a fantastic program in part because it's a pretty generous program. I mean, you know, my mother can go, she doesn't need to pick a primary care doctor, right? She's not in a Medicare Advantage plan. She can go anywhere she wants. She can go to any specialist she wants. You know, Medicare will cover anything. Yet, like Wendy said, they can negotiate price discounts, but they haven't been very good at controlling the volume of services. So, you know, I think of people I know on Medicare. I mean, go to the doctor. I mean, there's no barriers. And so, if you expand that to everyone, that's fine. But you really have to. You'd see the same inflationary problems if you didn't control the volume of services and maybe the payment system in terms of, you know, fee-for-service payment. And that, you know, we're going to hear from Vermont that's tried to move to single payer, and I think one of the issues they've had is how do you finance the system, because single payer, multi-payers, at some point you've got to decide what services are going to be covered and what services people are not going to be able to get in the kind of volume they want if you're going to control costs, and that's another part of the issue.
And I just want to add to that, because I think you make a great point. Unless you wouldn't necessarily deal with things that you talked about at the beginning of your presentation, right? We have an illness system, not a healthcare system. Our over-reliance on specialists and dealing with acute care after the fact rather, I mean, traditionally actually Medicare is getting better and under the Affordable Care Act. Medicare actually wasn't great on primary care and wellness. It really was a sick care system. So there's a lot of other things in the medical structure and culture, even if you're staying in the medical system and not getting to the population-based measures, that Medicare alone isn't going to get you to.
Okay, one more quick one.
Okay. A factor that drives up the cost that was not much discussed in the healthcare law is the malpractice insurance, and also the amount of money that goes to the insurers, that is the cost of the healthcare providers. Are in these two areas that some kind of control could be exercised, and what it might be?
We'll talk more about malpractice in the quality of care, which I don't remember the date right now, it's coming up. But I just want to say, malpractice is a very small part of the cost of the healthcare system. And we've had states that have had incredibly draconian malpractice reforms that have pretty much dried up malpractice. There really are like no malpractice cases, for example, brought in the state of Texas. It doesn't really change the cost. Malpractice, you know, we could talk about reform for its own sake. It's not a very good way of compensating people. It may not be very good at preventing medical injuries, 98,000 deaths a year, but it's not every study, and there's been a lot of empirical research, it doesn't seem to be a big factor in the healthcare costs.
That session, by the way, will be September 25th. That topic will be addressed. We're going to stop there. This is, in some ways, I think this has been a wonderful lead-in to next week's discussion called The Promise and Pitfalls of Obamacare, where we'll have John Auerbach and John McDonough from Harvard School of Public Health, who's done a lot. You know, both of them were very involved. Obviously, John Auerbach, as one of the healthcare leaders in the state, in the Massachusetts healthcare reform. Obamacare, there's a lot of similarities, right, between what Massachusetts did and what we're trying to do on the national level. So he'll talk a little bit about that, and then John McDonough has also written an awful lot and has been involved in Massachusetts reform and also looking at the U.S. reform.
Yeah, John McDonough was also working very closely with Senator Kennedy and stayed on the Senate after the senator passed and was involved in the drafting of the Affordable Care Act.
So we want to thank you all for coming to the first one and giving us a good kickoff, and hope to see you at as many as possible.